The gastric sleeve is an operation that has been available for approximately 5 years. It is a unique operation in that it reduces the capacity of your stomach. It takes a stomach that might hold 1.5 quarts of fluid and turns it into a tube or a sleeve that may only hold 3 or 4 ounces. The sleeve works not only by reducing the volume of food you eat and at what point you feel full, but it also reduces actual hunger. It turns out that that outer part of the stomach secretes one hormone called ghrelin, which is a hunger-producing hormone. Now, it's also true that it probably produces 30 to 40 additional enzymes or proteins that may have an impact on hunger and the food choices. When we look at long-term hunger hormone levels, it seems to be the lowest in patients who have a sleeve gastrectomy. With the sleeve gastrectomy, most patients will tend to lose about 70% of their excess body weight. The sleeve works in almost everybody, so there are very few failures. The risk profile is very good. It is equivalent to the safety of a gastric bypass and a band, and altogether all three are safer than really taking out your appendix. One of the few long-term side effects of the sleeve is related to what we call reflux or heartburn. Probably in the 5-year data, we're seeing about 10 or 12% of patients who develop gastric acid reflux. What that tells us is that in the beginning, we should study patients a little bit more thoroughly and identify not only the amount of reflux, the presence of a hiatal hernia, so part of the stomach may be protruding up into the chest. We want to see that the esophagus is emptying in a proper fashion. That's called motility. And lastly, we want to know what the pressure is in that valve between your esophagus and your stomach. Knowing that before surgery allows us to tighten that valve to fix a hiatal hernia. And so therefore, in most cases, we can prevent those issues related to reflux associated with the sleeve.